All right. Hello and welcome to the third webinar of a series of webinars on the new pulmonary hypertension guidelines of the European Society of Cardiology and European Respiratory Society. I'm Andreas Reimann from at Medicum, and we are very happy to support the Alliance for Pulmonary Hypertension, a non-for-profit organization based in Brussels that is supporting the PH knowledge sharing platform, on which also this webinar will be available later as a recording. I said this is the third of a series of webinars. The first ones were dealing with patient-reported outcome measures and shared decision making between patients and physicians. Now, these are very meta themes and subjects. Now, in this third webinar, we are talking about a very personal subject, and that is family planning and pregnancy. And I'm really honored to be joined by three women who are from different perspectives, will be talking and actually sharing with us their knowledge. That's Pisana Ferrari, who is Secretary General of the Alliance for Pulmonary Hypertension. That's Professor Dr. Karen Olsen from the Medical School of Hanover, and Dr. Esther Nossent from the University of Amsterdam from Medical School. Both are pulmonologists, and they will talk about different aspects of this subject. And I'm happy that Pisana will start off with her experience and her insights from a patient perspective.
Pisana, you're on mute.
Good afternoon, good morning, wherever you may be from. Thank you for the kind introduction, Andreas. It's a great pleasure for me to be invited to speak today on a very important topic in pulmonary hypertension. For those of you who don't know me, I was a PH patient for 14 years, and I underwent a double lung transplant 21 years ago. And I've been a patient advocate since then. I'm here today both as president of the Italian Patient Association as well as Secretary General of the Alliance. So regarding the content of my presentation, I'm going to start by some patient testimonies. I collected a number of testimonies from a discussion on a message board and through PHA International. And I'm just simply quoting them in the next two slides. Then I'm going to be looking at what these testimonies reveal as seen from the patient standpoint, what they reveal from the healthcare professional standpoint, what the new guidelines say. So next slide, please. I'm just reading them out. Not all patients are interested in having children, but for some, it's a continuous trauma to overcome, especially in the fertile age and society we find ourselves in. I always told myself, well, we can adopt, but I was advised not to because children can carry diseases. It's like having a wound that's always open, even though over time you learn to live with it. The topic of children is very delicate. I have been living with choices made and choices forced upon me for 20 years. The weight on the conscience is heavy. This is a patient who had an abortion. There's certainly no right way to say it, and the abrupt way is probably more impactful, but one should bear in mind the sensitivity of the other person and recommend psychological support. I was on the waiting list for a transplant and could not get a health certificate for the judge, so it was not possible to adopt. We decided for surrogacy. This is a criminal offense in my country. We had to go abroad. It's been 2 years now, but I'm still going around shops for children's clothes. Next slide. I initially found out about it online. Then the PH Center called me while I was driving, saying they had forgotten to tell me. Closed doors and those words that still resonate. At my PH Center, they described pregnancy as flipping a coin. One doctor said that the very mention of the word made his hair rise on the back of his head. I was prevented from having ovarian stimulation for in vitro fertilization as PH could worsen. The constant anxiety about contraception adds to an already restricted sex life. More efforts should be made to help in this aspect. The issue with pregnancy influenced my relationship with my ex-partner. It was hard for him to accept it and also for his family. If they tell you for a pregnancy you should suspend all medications and spend 9 months in hospital, would you still do that? Currently, I believe there are no medications compatible. I always thought that a child should not be allowed to have the same thing that happened to me and my mother. This was the only male patient. He had familial PH and he lost his mother to PH as a child. I always dreamed to be a mother. This dream has been crushed. Next slide. So what do we see from these testimonies? Sorrow, grief, regret, a very heavy emotional burden for patients, partners, and families. This is additional bad news on top of an already very severe diagnosis. As you've seen in one of the testimonies, there's also societal and family pressure for women to be mothers. There are sometimes very painful decisions to have to make, termination of pregnancy, for example. It's difficult to try for alternatives, IVF, adoption, and surrogacy. These are not available in all countries. It's not always possible. Sex and contraception are a challenge. There's a lack of information or incorrect information, and very much the need for empathic and sensitive communication to take into account this very heavy emotional burden. And actually complete change in life projects, family planning, and a very, very heavy burden. Next slide. So from the healthcare professional side, the lack of a scientific consensus on the topic is a problem. This makes it difficult for healthcare professionals to handle the issue. It's very painful news for them too to give to a patient and to their partner and family. Delays in giving this news may be due to reluctance to overwhelm the patient at the time of diagnosis. I'm guessing here, our doctors will tell us more. Termination of pregnancy is not only emotionally difficult for patients, it's also very difficult for healthcare professionals. And having to manage a pregnant woman with PH is challenging. There are a lot of risks and a lot of issues involved. We'll hear more about them from our medical experts. This is also the case for contraceptive advice. And finally, there are limited treatment options in case of pregnancy. Next slide, please. So today we're here to talk about the new ESC-ERS guidelines. And I've put here side to side the previous ones that were published in 2015 and the new ones, which are the ones with the yellow highlights where I've taken out the points that I'm going to show in the next few slides. Please, next slide. So this is a table with the recommendations. As you see in the 2015 guidelines, it just said it's recommended that they avoid pregnancy. So the 2022 guidelines have a much more nuanced approach. It's recommended that women be counseled about the risks and uncertainties, which should include advice against becoming pregnant and referral for psychological support where needed. So you see there is a big change here already. There are also other parts, if we can move to the next slide, here too, where there was nothing in the guidelines and there's now something. Next slide. I won't go into this in detail because Karen and Esther are going to be looking at this. We move on to the next slide. Next. Okay, so how do the guidelines address these issues? First of all, and this is very important, they acknowledge that it is a very sensitive topic, which requires empathic communication and potentially also psychological support. There's a big stress on the need to provide all the necessary information for women to effectively make an informed decision. And shared decision-making is a theme that comes right through the guidelines in 5 different sections. The guidelines also acknowledge the need to consider and respect patients' individual needs and choices. They recommend that contraceptive advice should be clear and consider individual needs. And they mention, for the first time ever, adoption and surrogacy as possible options, wherever applicable, of course. They mentioned also, for the first time ever, genetic counseling. And finally, in the case of a pregnancy, they recommend that it be managed by a multidisciplinary team in a center experienced in managing pregnancy in PH. My final slide. I had the great honor to be involved in the task force writing the new guidelines. I think there were 2 patient representatives, and we were therefore able to bring the patient perspective. And I think there's a much more comprehensive section with respect to the previous guidelines. There's a new table. There's a much more participatory approach versus top-down before. So women now have a say. They can, express choices, make informed decisions. There are many new and positive elements, certainly. Beyond medical considerations, of course, there are also cultural, religious, and personal beliefs, and these play key roles, and they add layers of complexity to a very difficult decision. It's a delicate journey which requires a comprehensive understanding of each individual's unique circumstances and values. So to conclude, the issue of pregnancy remains open, but pulmonary hypertension is still today an evolving, dynamic field of medicine. There's been huge progress made in the past 30 years, and things would still change with time, new drugs, new interventions, new scientific advances. I was diagnosed with pulmonary hypertension when I was in the late stage of my pregnancy. It was a very difficult journey, but today things are very different, and in future they could be even better. And I would like to end with a note of hope. Thank you very much for your kind attention.
Thank you so much, Pisana, for sharing also your personal experience and the many testimonials of patients with us. This is a very personal and a very touching issue, and they are changing. It's an evolving medical field, and I'm very happy that Dr. Karen Olsen will now share with us the latest news about and findings about pregnancy and PH. Karen.
Yeah, thank you very much for the kind introduction. I will just shortly share my screen, if it does work. Yes, and I also have a quite emotional, I think, relationship to the topic. What initially started for me as a project, or as my first real project in PH, over time became like something like a life task. And to explain a little bit how or why we had this really harsh and top-down recommendation, I would like you to take back a little bit in history of the guidelines and in pulmonary hypertension, and show you some data which at least partially explains why this recommendation, or where this came from, and why we are still discussing a lot on pregnancy, and sometimes are really reluctant for our patients. So these are the 2009 guidelines. Where
Karen, I'm afraid at least I am. Oh yeah, here we go. Yeah, now we can see. If you go to the presentation mode, that'll be lovely. Yes.
Yeah. I was in presentation. Can you see the slides move? Because I can't see.
Yes. Now we can see.
Okay. So in 2009, the recommendation also said its recommendation is recommended to avoid pregnancy in patients, and this didn't change in 2015. But I think what changed was the reality. I think we always had patients who became pregnant, or who wanted to become pregnant, and who were more informed, and we had emerging therapies. So this is one slide I love to show, because these are the guidelines on that time, and the reality is the note where our nurse wrote down, "Patient is pregnant, please call back." And this is the situation we were in as physicians. What is behind? Why is pregnancy so detrimental for patients with pulmonary hypertension? There are physiological changes during pregnancy. We have an increasing blood volume between 40 to 100%, with a maximum in between gestational weeks at 28 to 34. And of course, we have this well, it's not a real anemia, but we have the red blood cell mass, which is only accelerating around 25%. So we have this kind of relative anemia. And the cardiac output needs to increase about 30 to 50%. We have to increase stroke volume, but we also have to increase heart rate to achieve that. And what we also see is due to progesterone and NMO and prostacyclins, the systemic resistance is decreasing. And also around the birth, and we have pain, we have sympathetic activation, we might have acidosis, volume shift, hypoxemia, and also danger of embolism. And these are all reasons why pregnancy might lead to right heart failure in our patients. I try to collect some data for you over the years and try to explain this table a little bit. We have data which is mainly from the developed countries, because I think this is what this is better to compare for you. We have here, if you see the year, it is then the time period and the etiology and infant and maternal mortality. And what you can see is that in the years where we did not have therapies in the first two studies, maternal mortality was up to 56%. So more than half of the patient or the mothers died during pregnancy. And I think this shows quite clear why we could not recommend patients to get pregnant with pulmonary hypertension. However, this was the area which you can see with the red line, where we did not have therapies for pulmonary hypertension or pulmonary arterial hypertension. If you look at the studies below, you see that the mortality of the patient is declining. So you have 33, and in the later years, our study together with our European colleagues from 2012, we have 12% mortality and 17% mortality in the Duarte study. If you look at data after 2015, so we have a study with around 16 patients and 25 pregnancies. We had no maternal mortality. However, there were 2 transplantations, and a study from our Swiss colleagues who had 7 pregnancies and 5 patients with no patient dying, and I think this was also a good sign. What we learned from the studies is that patients who are calcium channel blocker responders are at lower risk. Well-controlled pH is lower risk for a pregnancy, and a low PVR on therapy. However, patients who got pregnant for the first time or had uncontrolled pH, who had a high PVR, were at higher risk, and general anesthesia, and of course, I think this is one of the main points, emergency setting is of risk for our patients. We have then developed an algorithm at our at Hanover Medical School, how we treat patients who consider to get pregnant or becomes pregnant. We try to offer a consultation as rapid as possible. We do a thorough clinical assessment, but we also let the patients be seen by our transplant specialist, obstetricians, also psychologists if needed. And we have this approach of shared decision-making. Sorry, I have this problem with the system, which and we do a clinical assessment if the patient gets pregnant every 6 to 12 weeks during the first trimester, and every 2 to 4 weeks during the second trimester. And we focus on echocardiography, NT-proBNP, and fetal development. Of course, the endothelin receptor antagonist is discontinued. We do not routinely initiate prostacyclins, but we do if patients tend to decline. We do every time a basic evaluation for transplantation, and I think what's very important is to plan everything. So we have a planned delivery around the 38th gestational week. Of course, there might be indications where we have to do it earlier. We always have a multidisciplinary team involved. We do a C-section. We might later on discuss the mode of birth, and we have peridural anesthesia to avoid general anesthesia and close monitoring of vital signs. And we also do, if the patient is not deemed stable, we have ECMO sets inserted before the delivery to be prepared in case of emergency. And also the patients are monitored at least for one night at the ICU. So the mode of delivery is always a matter of discussion. I think the vaginal birth, of course, have some advantages. We have less blood loss, we have fewer infections, of course, less thromboembolic risk, and the hemodynamic changes might not be so abrupt. However, I think the main problem is that the timing is not possible, so you might end up with the youngest assistant in the emergency room and have a high-risk patient. So you have an increase of cardiac output and of the venous return during the contractions, and the prolonged labor might be detrimental for the patient. And I think it's at all not predictable how everything goes during the vaginal birth. And also you have the risk of emergency cesarean section and intubation, which is often detrimental in PH patients. And this leads me to the point why we prefer the cesarean section, that the timing is possible. You have a routine setting, you have an experienced team. We have sometimes up to 20 persons in the room. You can do ECMO standby, you have regional anesthesia, and of course the controlled situation, which is, I think, the controlled and the standardized situations is, I think, the main goal we have to have in patients who get pregnant with PAH. But of course, we have severe other problems. We have the blood loss, we have the danger of infection and inflammation. We need anesthesia. And of course, if we need ECMO, we have the risk of bleeding complications. So, and also there's often discussion on ablactation. There's no data how to perform ablactation and if it has any advantages for the patients, and if the prolactin, as in postpartum cardiomyopathy, has a detrimental effect. However, it has the advantage that the therapy can be reintroduced, and the childcare is at least partially independent of the mother, and the patient can have support to recover from the birth. So still, there remain a lot of open questions. So how is the risk of pregnancy in patient with controlled disease? Do we have the risk that the patient do decline? Can it accelerate the course of PAH? And how can we manage patients with severe PAH who become pregnant? How does the offspring develop? And we try to address those questions in our paper, which I already shortly managed. And to put it all together, we had favorable outcomes, moderate, but we also had unfavorable outcomes. This is what we have to say. We had 25 pregnancies in 16 women, which I already told you, in between 2007 and 19. 17 were successful. We had also one Gemini pregnancy in a responder. And all children, which we were very happy to see, developed normally. And 14 of 16 patients are in stable condition without lung transplantation, and 2 required lung TX. In the meantime, we had a third patient who required lung transplantation. We also had 8 abortions, of which 5 were spontaneous, which is, I think, quite the normal percentage of pregnancy who have spontaneous abortions, and 3 induced abortions due to medical reasons. But we also had worsening in 6 patients within 9 to 22 months after birth, but they all stabilized under intensified medical therapy. We had those 2 patients who required transplantations, and we had any kind of worsening, if you put it together, in 50% of the patients. So in summary, pregnancy continues to be associated with the risk and uncertainties, and the outcomes have improved in the modern treatment area. And I think pregnancy remains or is a really sensitive topic that needs to be discussed on an individual basis, taking into account the current data and uncertainties. And I think this was the main point and what we wanted to reach in the guidelines. We have to have an individualized risk-based approach. We have expert consultations, and we have to have shared decision-making to have the best possible, and we have standardized care to have the best care for our patients with pulmonary arterial hypertension. So thank you very much.
Yeah, thank you very much, Karen, for this very insightful sharing of the actual knowledge. And I should say at this moment that you're also co-authoring as Pisana the new guidelines. So this is firsthand experience. And I'm very honored now to hand over to Esther Nossent from Amsterdam. You're a pulmonologist, but you're also heading up and dealing with multidisciplinary teams and discussing also other aspects of birth control and family planning. Esther, the floor is yours.
I will first unmute myself. Thank you for the introduction. And I hope now when I share my screen that you see my slides and also moving. Thank you. These are my disclosures for today. And what I'm going to talk about in the next 15 minutes is we already heard a lot of from Pisana and from Karen and about this difficult topic. And what we also would like to illustrate and talk about today is how a multidisciplinary team in a pulmonary hypertension center should work for patients with pulmonary hypertension concerning family planning, birth control, and pregnancy. And that's also in line with the new guidelines, of course. And I also want to focus on the most important issues to consider in birth control methods, especially when you have pulmonary hypertension. And when I was asked a few weeks ago if I wanted to talk and give this webinar about this subject, I remembered a patient of mine not long ago, and this is really where this is all about today. That's a female patient of 29 years, and a few months ago she collapsed at a party. And she had an unremarkable medical history, and not long after that she was diagnosed with idiopathic pulmonary arterial hypertension. And she was started on medication, pulmonary hypertension medication, tadalafil and ambrisentan. And one of the, when she got a diagnosis, and we heard from Pisana, there's a lot of information then, a lot to deal with. And one of the first things she asked me is, and now I wanted to start a family. And that's, of course, a very important question. And it's also a very personal question, different for every patient. And if you take a look at pulmonary hypertension care, and that will be in every pulmonary hypertension expert center, in Amsterdam, we developed a model for the patients, but not only for the patients. Of course, it also concerns partners, family of the patient. At time of diagnosis, there are a lot of issues you need to discuss, but it's too much for the first time. And of course, timing to discuss all these different subjects is also different for every patient. Everyone has a different personal need, of course. Most of the time, if you can see on the right side, it starts with education of the disease, with medication, but also, of course, genetic counseling, nutrition and lifestyle, psychological support, workability, and even later also future perspectives, even transplantation, all very important issues. And also, of course, family planning, birth control, and pregnancy. And this is where we talk about today. And what I quite often do, or what we do, is that when the patient gets the diagnosis, or we get to know each other, then we mention all these subjects, and then together with the patient we decide when is the best timing for you, and what do you need at this moment to discuss all these different subjects. And of course, one patient wants to talk sooner and has sooner questions about, of course, family planning, birth control, and pregnancy, especially in patients of young female patients with childbearing age. And that is the subject of today, and that is a very difficult and a very personal subject, of course, and that is already mentioned a few times. And I'm going to repeat a little bit, but I think it's important. Why is this such a difficult subject, and why does it need so much attention? Well, we know that pregnancy and pulmonary hypertension, Karen already showed us, there is a risk of maternal and also fetal death, and there's a risk of worsening the pulmonary hypertension, that patients develop right heart failure. But also with that, there's a risk of spontaneous abortion, that the fetus, the baby, doesn't grow good enough, or that there is a preterm delivery. So you all have to consider that. And also the medication we give for the pulmonary hypertension might be harmful for the fetus or the baby. So that's also something to take into account. And what also Pisana told us, sometimes pulmonary hypertension, and not we see that even quite often, is diagnosed during pregnancy. And of course, that really needs a different approach in those patients. And but on the other hand, the last few years we have seen successful pregnancies, labor and delivery in patients with pulmonary hypertension, especially when the pulmonary hypertension is well controlled, and when patients respond well to calcium antagonists, so the medication. So that really makes that the decision, can I become pregnant? Should I become pregnant? Do I want to become pregnant? Is really an individual decision, and also we can only give advice on individual basis in that. But it's really difficult because of also the open questions which are still there, which Karen showed us. When we go back to the medication in pregnancy, this is quite important. Of course, we treat pulmonary hypertension with medication targeting 3 different pathways, and especially the endothelin pathway, and that is what you know as the bosentan, the ambrisentan, and the macitentan medication. Is harmful for the fetus and the baby. So we should stop that, just like Riosgat and Selexipag during pregnancy. And there are limited data concerning the other medication like sildenafil and like tadalafil and epoprostenol, but we consider them safe and we can use them during pregnancy. A question I get a lot the last few months, and I think Karen also, is how about sotatercept? Maybe you've already heard of it, but it's one of the new pulmonary hypertension medication, and we expect that it will be registered and approved in different European countries, I hope, next year. And it has really promising effects for the treatment of pulmonary arterial hypertension in patients. So it maybe gives also opportunities to better control the pulmonary hypertension, that it gives a possibility for pregnancy. But on the other hand, we have no data yet, and we don't know yet if you can use it safely during pregnancy. That's still also an open question. And there are quite some thoughts, because it's quite a large molecule, so that it might not pass the placenta. But like I said, that's still an open question we should answer. And if then we go to the subject and discuss with the patients about birth control, pregnancy, family planning. This is what is in the guidelines, and it was already said, and that's also what the guideline said. Inform your patient well. It's a shared decision making, individualized advice, and what I really want to say and make sure you're one step ahead. So when you're talking about this subject, and this is not a subject you can talk over and make decisions in 5 minutes, of course. It will take some time. So also when it takes some time and you're in this process, it's important also to give information and make decisions concerning birth control, of course. And if most of you will be treated by a pulmonologist, or in some countries also a cardiologist, but of course not the pulmonologist and the cardiologist is not alone. We're a complete team in the centers. It's also specialized nurses, clinical geneticists, social workers, psychologists. And of course, when it comes to family planning and pregnancy, then the team even gets bigger. Then we also have a gynecologist, a pediatrician, an anesthesiologist, an intensive care specialist, all knowing about pulmonary hypertension and having experience in pulmonary hypertension and handling pregnancy and giving advice for the individual patients. And maybe in your center, expert center where you're treated, it will be a little bit different, but every center dealing with this will have such a team. And I think also that is an important issue. And then if we talk about it, the family planning, what are the issues we consider and where should we talk about? And of course, for the individual and for the patient, it's important to think and to talk about what kind of pulmonary hypertension do I have? What kind of medication do I use for it? Is that medication, can that be harmful for the child? And that's not only in pulmonary arterial hypertension, of course. You also can have to think if you have a chronic thromboembolic pulmonary hypertension. By example, vitamin K antagonists, so anticoagulation to make the blood thinner. We cannot give in the first trimester of the pregnancy. So also you have to reconsider that. And if you have pulmonary hypertension concerning connective tissue disease, then some immunosuppressants can't be given during pregnancy. So that's important. And if you have pulmonary arterial hypertension, do you respond well to calcium antagonists? And how severe is it? Or is it well-controlled pulmonary hypertension? And then it's always difficult, and that are the open questions. Can we say, is there enough reserve of the right ventricle to have to deal with all the physiological changes Karen explained during the pregnancy? But it's also important to educate and to discuss what are the risks of some pregnancy, where do I have to think of? And then you can come together to an advice and a decision. And also what is mentioned in the guidelines and what is new is that what we should discuss is also other options. And this is different for every country because there are all different legal advices in countries, but adoption, and this is also, of course, personal choice, but also surrogacy in some countries is an option. And what I also always discuss is what if you do not become pregnant or not able to become pregnant. There can be different reasons for that. And then we always get the question like IVF, in vitro fertilization, is that possible? Because there are really limited data and not a lot of experience in patients with pulmonary hypertension. And that is because we're quite careful with that because of if there are complications of the treatment, you can have a lot of fluid fluid overload, which can be harmful for the patient with pulmonary hypertension. So also there, we are quite careful and difficult, but I think at least we should discuss what is possible and what is not, of course. And next to this, there are also other things to consider, and there I think, very sensitive things. But I already saw it in the chat, one of the questions, that how about genetic counseling, and especially also preconception genetic counseling? Because if you have an heritable form of pulmonary hypertension, sometimes patients know that, sometimes they do not. But what does it mean for, to give possibly a disease to your offspring? And in some European countries, there is also a possibility of pre-implantation genetic testing, which means that embryos are selected before placed back into the mother if they do have or do not have the genetic variation which gives the disease, which can give the pulmonary hypertension. But that's, of course, if you want to do that, that's a personal choice, of course, not available in every country. But also it's a very difficult topic because you need IVF for it, and that can also be risky in patients. But it's important that we all know it's there, and how we should deal with that and discuss it at least. And of course, there are also very practical aspects from what does it mean to take care of a child when you have pulmonary hypertension with less exercise tolerance, less energy maybe. That's also important to consider. And very difficult, but life expectancy. What does it mean for you and your partner to take care of a child when in the future your disease might worsen and maybe heart-lung transplantation is needed? And also that is, of course, for everyone, is that a personal thing and can be different for every patient. And those last things I mentioned is, of course, not only for our female patients, but this is exactly the same for our male patients with pulmonary hypertension. And I think ook important we discuss that with them. And if we then stay for a little bit with the male patients, then of course, when they would like to conceive a child, it's also important to consider the medication we can give for the pulmonary hypertension, and we can give those medication without problems. But there are some data and some discussion that some of the medication might affect the quality of the sperm cells. So that's also important to consider, especially when there is less fertility. And then finally, also when all the discussion is going on and you talk about this, it's also important in the meantime or after that, especially when there is discussed or the decision is not to become pregnant, or that, of course, birth control. And there are a few issues also in pulmonary hypertension we should consider, which is different. And especially that, of course, barrier contraceptive methods like condoms are safe, however, unpredictable. So if you consider oral contraceptives in patients, then there are two things, and especially that in contraceptives which contain estrogens, so certain hormones, then there is in the general population, so with everyone, there is an increased risk of developing venous thromboembolisms. So that are emboli, so thrombosis of your legs or in your lungs, so pulmonary embolisms. And that are blood clots in your blood vessels in your lungs. And they can worsen the pulmonary hypertension. So that's a reason why we are very careful with that. And also very important to consider is that if you use Bosentan, we know that the efficacy of most hormonal contraceptives is reduced. So they do not work that well. So that's also an important thing to consider, of course. If you then go to the intrauterine devices, they are safe in pulmonary hypertension. We are, of course, a little bit careful because when they are inserted, it can give a vasovagal reaction, and that's sometimes not well tolerated if you have pulmonary hypertension. And also the copper intrauterine devices can give more infection. So in congenital heart disease patients, we are quite careful with that. And there are, of course, also more definite methods of birth control. So if there is a conversation or it's considered sterilization in female or male, then it's important to consider that in female it are surgical procedures, and there are some perioperative risk, and especially the risk of general anesthesia, and more often the male sterilization, which can be under local anesthesia, is a little bit of an easier procedure and has less complications. So that's also something to consider. And for that, I want to conclude, and I have a very short conclusion because I think it's important that this subject is important, family planning, birth control, and pregnancy, but it's also very delicate. But I hope I have showed you that we need to talk about it, and then we can make good decisions, hopefully for every or most patients. And we should have time now for the discussion, so let's talk about it.
Yeah, thanks you very much, Esther, for sharing with us your knowledge about the issues around birth control and family planning in PH. If I may summarize, Karen probably pointed a little bit more to the opportunities, while you were a bit more careful. Please correct me if I'm mistaken by that interpretation. And you can do that in a minute. We do have a first comment from Melanie, and probably we can discuss this. Melanie says, I do think that indeed the timing to inform a female patient about the situation about pregnancy is extremely sensitive. It should be done as early as possible, but you also need to make sure the recommendation will be well understood and that it will not make the patient reject everything about treatments and probably not going into a treatment. Probably we can discuss this, and this is a reminder for everybody here in this webinar. Please, if you have questions, if you have remarks, please use the chat function, and we will be able to discuss it here. So who wants to start? Probably Karen.
I might. So I think this is a real good point, which Melanie is making. I think the time point, and we also try to address this in the guidelines. I think you need to address the issue right at the moment, of course, or at the earliest possibility. At least you have to say that for the moment, at the time point of diagnosis, it's quite clear that pregnancy is not an option and dangerous, and that you have to delay this discussion to at least a later point, because you have to administer therapy, you have to see what is the course, and then at a later state of time, I think you have to postpone it, and then have a risk evaluation, have to see how everything goes, and then discuss the topic again. Of course, you have to address all the dangers of pregnancy at that point. And this is at least how we do it at the time point of diagnosis, that we mention it, and we say that at the time point of diagnosis and before any kind of therapy is securely introduced, this is no option, and this is dangerous. And then we continue with the discussion.
All right. Is there any remarks from your side?
Yeah, I completely agree. But what I've also said is that there's a lot of information when you get a diagnosis, and a lot of things to consider. There comes a lot to you. That's also what Pisana said in one of their patient testimonies. So I think it's also different for every patient. When should we start with the discussion, and when should we give the education and talk about it? And you said I was a bit more careful than Karen. I don't know. I think no. I think we all have the same view that we should focus on the opportunities, and that there's a really shift in the guidelines and a shift in the thinking of all the healthcare professionals and also in the patients, that there are more possibilities. But of course, we have to be still careful. and make a very good individual risk assessment, of course. And also the wishes of every person, every individual is different. So we all have to take that into account.
Thanks. Pisana, to what extent can patient organizations support the exchange between women who want to or who may consider pregnancy while having PH and those who went through that experience, either with a successful pregnancy or with an unsuccessful pregnancy? Because talking to each other may help, and may help also to make a informed decision. You're on mute.
It's a very personal topic and very sensitive. It's not something that women really want to very much talk about and share. I found when I launched this discussion on a message board and through PH International that I was expecting more responses. I was expecting more discussion. I think it hurts badly. It's difficult to talk about something that hurts so bad. And you've heard some of the testimonies. I've also seen some successful surrogacies, adoption, and everything. But it is something in our society. I think societal pressure is a big thing too. Husbands can be a problem. Families. You feel that in some cultures, especially, I come from Italy. Being a mother here is a very important thing, and if you can't be, it can affect your relationships. So there is no, to my knowledge, there's no chat where women talk about it.
Right.
And I'm not sure that it would actually be possible, but it could be.
Karen?
Yeah, I might jump on it again. Yeah, I really agree with you, Pisana. We have sometimes a quite different experience in our patient forums, where if we touch the topic pregnancy, we had patients from all over Europe, or at least the German-speaking countries, coming in to discuss on that topic. And maybe you said I'm more optimistic, but I don't know. We have also experienced a lot, and I think today is a really bad day to discuss this topic, because even today we have to give up a baby to save the mother's life, and even if we do that, we're not sure we succeed to keep a mother which has or who has a PVOD, if we can save her, or at least save her for a long time. So I think it's also for us, it's every time it's an individual discussion, and sometimes we can't leave. Even if I'm an advocate for the shared decision making, today we had to take the decision for the patient, and it changed a lot. What we have to do is, I think, to take the judgment out of what we are doing, and to come more and more. That it has made me really angry in the beginning when I started, because it was the sentence, and we tried to avoid any kind of discussion with that, avoiding women to get pregnant or ask about it. And we have to come to a standardized care. We have to generate data, and we have to have the best medicine for our patients. And I think this is what we want to do. We can't or help every patient, or can advocate for pregnancy in every patient, but we have to advocate for the best kind of medicine. This is what we have to do.
We had Pisana?
No, I just wanted to say that I was diagnosed 35 years ago during pregnancy. At the time, there were no drugs, no expert centers, no clinical guidelines. There was nothing happening. And so much has changed since then, if you think about it. So I'm hopeful that with future advances, things will improve even more. So I think, so much has happened, and we can be at least hopeful for the future.
Well, what we certainly see is that this is a very individual decision, and it is a decision that needs very insightful consultancy by expert centers. Now, if you look to in the knowledge sharing platform of the Pulmonary Hypertension Alliance is a global resource actually. If you look to on a more global level, what would be your advice to PH patients, female PH patients, not at your sites, not at your centers? How can they find PH specialists who are really knowledgeable about pregnancy, birth control, and family planning in PH? Esther, or Karen? Go ahead.
I'm not sure. It is difficult to answer. What we do receive on a regular basis is, for example, from patients in Africa or from all over the world, to how to manage pregnancy. And I think if the patients go to their PH center, we are all, I think, quite well connected and talk with each other. So they might address centers with more experience. However, still there's the problems. You have different resources, different medications, different options in different countries. So one or a woman in Africa, or just depending on the country, might not have the same medication or the same medical care, or even afford to ablactate if she wants to feed her baby. So these are, but still it's also communication and networking. And I think we have to do more on that topic, and maybe on a really broader basis to organize. I think we hope to address that soon, at least on a European basis.
Is there any additions to that?
No, I think Karen, said it quite well, and it's a difficult thing. We want to have good pulmonary hypertension care, of course, all over the world, but we have still, especially in this topic, a very important task for some open questions we have to answer the next few years, and then also making sure that there is knowledge and good care in every country, but there are quite some steps.
Yeah, and actually the knowledge sharing platform can be a very good resource for information and for sharing that knowledge. And so we will have that webinar also displayed on the knowledge sharing platform, so everybody can watch it again. And I encourage everybody on this webinar to share it also with other patient communities, and even probably, if possible, to translate it into your local language, or to have a small webinar in your community, so you can share that information. One final question regarding adoption that was a bit discussed in the chat as well. Often adoption requires a medical statement that the mother is able to take care of the child in the future. Of course, that's very difficult to predict, because we all nobody can look into the future. Did that change as well? Did the perspective of young women who want to adopt children change from your point of view? Karen?
Also difficult to answer, because it depends on the legal situation in your European country. Here, especially in German, you have health restrictions, and you need, of course, certificates, how Pisana just told us before, which say that you are, or your life expectancy is not impaired, for example, or you have to prove that. And that makes adoption, even if the patient is in a very good state, sometimes impossible or very difficult. So I think it's a very controversial topic. I think many laws, for example, also like egg donation, surrogacy, might change in the next years, but I'm not sure when it will happen and how it will happen and if it will happen.
Is it?
Yeah, and just to also, I think it has at least changed a bit, that with the introduction of the medication and the life expectancy is really better than it was 20 years ago. It changed at least a bit, which helps us if we have those questions. And but it
Yeah.
depends really on the European country. Every country has different rules.
Thanks. Pisana, to conclude, what would be your take home for all women who have watched us today or will be watching that webinar?
I think all women who have PH should be treated in an expert center. That's my key recommendation, not just for pregnancy, for everything. And I think that's the key to it. That's the key to the problem, really. Unfortunately, that's still not happening, and that's essential.
Thanks very much, Dr. Noscent, Dr. Olsen, and Pisana Ferrari for joining us today. I'd like to invite everybody to join us again on October the 12th, when we will be discussing with two very famous PH experts, Marius Hopper and Olivier Sidbon, about the updated treatment algorithm for PH. Stay tuned then, and I wish you all a very nice remaining day. Thank you very much, and goodbye.